This is the videotaped deposition of Dr. Curtis Partington. This deposition is being held at 8338 Suma Avenue in Baton Rouge, Louisiana on October 17th, 2019 at the time indicated on the video screen, which is 12:55. This time, would counsel please introduce themselves for the record?
Peter Ellis on behalf of the plaintiff, Miss Mickey Singleton.
Sid Hardy on behalf of Walmart.
Do you solemnly swear the testimony you're about to give is the truth, the whole truth, nothing but the truth, so help you God?
I do.
Would you give us your name and address, please, Doctor?
My name is Curtis Ray Partington. My office address is the Imaging Center of Louisiana at 8338 Suma Avenue in Baton Rouge.
And, Doctor, before we go forward, counsel has something you'd like to put on the record.
Well, we agree to stipulate to the expertise of Dr. Partington as a neuroradiologist. We'll also like to place a continuing objection as to the topics in upcoming motion in limine, specifically to the scope of Dr. Partington's testimony as to causation, symptomology, or treatment, given his expertise in radiology, in addition to subject B, which would be any unrelated medical conditions outside of just the cervical opinion.
Okay. Counsel, I appreciate you agreeing to stipulate to Dr. Partington's expertise, but I'd like to ask Dr. Partington a little bit about his professional background, his training, his education, and the kind of work he's done for the benefit of the jury. So, once again, I appreciate your stipulation. Well, Doctor, tell us about your educational background, please.
Sure. We'll just start with medical school.
Start with medical school.
That'll be shorter.
Yeah.
I went to medical school at the University of Miami, where I received my MD degree. From there, I moved to the University of Wisconsin in Madison, Wisconsin, where I was an intern for a year, taking care of sick people in the hospital like interns do. I then stayed at the University of Wisconsin in Madison for a residency program in general diagnostic radiology. That is, 4 years of learning how to look at chest x-rays and x-rays of broken bones and CAT scans of your abdomen and all those kind of tests and make a diagnosis based on those tests. After I completed my general diagnostic radiology residency, I took both written and oral examinations, which I passed to become board certified in general diagnostic radiology. I then stayed at the University of Wisconsin in Madison for 2 additional years of training in neuroradiology, which is the subdiscipline that deals with diagnostic imaging of the brain and spine. After I completed my neuroradiology fellowship, I stayed at the University of Wisconsin teaching neuroradiology for a few years. Then my wife got recruited to be a faculty member at the LSU Vet School, and we moved to Baton Rouge in 1991. After I'd been in Baton Rouge for 4 years, they created a board of neuroradiology. So I got to take another written and oral examination, which I passed to become board certified in neuroradiology. That's one of those awful things that expires every 10 years. So I got to do that again 10 years later. I took another written and oral examination, which I passed again to become board certified in neuroradiology. That came up again about 5 years ago, and I elected not to take the exam. So my neuroradiology board certification is no longer current, but I'm still board certified in general diagnostic radiology and practicing mostly neuroradiology.
And Doctor, would you briefly explain to us exactly what radiology encompasses? What does a radiologist do?
Sure. Well, in particular, neuroradiology was the topic today. So what I do in my day-to-day work is I look at MRIs, CAT scans, myelograms, mostly of the brain and spine. I look at those, make a diagnosis as to what the abnormalities are on these tests and what could have caused them. I relay that information to the doctor who ordered this test. So one of the local doctors, a neurosurgeon or orthopedic surgeon or whoever, will think his patient needs an MRI or a CAT scan of their neck. They'll send them to my office. We will do that test. I will make a diagnosis as to what the patient has on that test and what could have caused it. and relay that information to the doctor that ordered that test. And that's kind of how I spend my day, all day, every day, when I'm working.
When you say you give your interpretation or diagnosis as to what the pathology is and what may have caused it, is that generally within the scope of what radiologists do?
Sure, that's exactly what radiologists do.
Okay. Not just neuroradiologists.
Correct.
And causation is, or medical causation, is something that radiologists are trained to recognize and to identify?
Sure, it is.
Okay. Do you make comments about medical causation in terms of those cases or films that are referred to you by physicians and not lawyers?
Yes, I do.
Okay. What I'd like to talk to you now about is how you came to be in this case, and you've done a film review. I know doctors send you patients to, or have them undergo tests and send you the film to evaluate, but you also work with attorneys, is that correct?
I do, yes.
And would you tell us about that side of what you do?
Sure. I have another business providing second opinions of diagnostic studies, mostly spine and brain cases, to attorneys, both defense attorneys and plaintiff's attorneys, as to what I think the diagnosis is and the causation is. And so that's a business I run outside my normal medical practice, and it's been getting busy. I do one of those a day, every day. So that's kind of my typical caseload of doing that. My current statistics are 80% of those come from the defense or the insurance company, 20% come from the plaintiff's lawyers. So I work on both sides, because this is just anatomical data, and I'm looking at the images and making a diagnosis. I don't have a side. Doesn't matter to me. So it's easy.
Do you read these images or study these images and give conclusions any differently in those cases referred to you by lawyers as opposed to those cases that are sent to you by doctors?
No, I do them exactly the same. My report format is exactly the same, whether it's done in my office at the request of another doctor, or whether it's sent to me for a second opinion from a plaintiff's lawyer or an insurance company.
Do you, in the course of your attorney referral matters, do you ever let the lawyers know, or in some way, that what you saw is not particularly helpful, or you just shoot it straight?
I just shoot it straight. I don't have a side. Does not matter to me.
And let me see. Do you customarily read the previous radiologist report in connection with the lawyer referral cases prior to your review of the film?
No, I do not. I do not read the other radiologist report, either before or after my review of the film. Because my job in providing this second opinion is to provide a second opinion as to what these diagnostic studies show, not whether or not I agree with somebody else. So I just don't do that. It's my policy not to look at the previous report.
And at this point, I'm tendering as an expert in radiology and neuroradiology, which I understand is already been stipulated to by counsel.
Objection.
I'd like to talk to you about this particular case, Miss Mickey Singleton, and I believe you were sent some diagnostic film for review. Is that correct?
Correct.
Tell me what you were sent.
I was sent a cervical myelogram and post-myelogram CT scan from the Spine Hospital of Louisiana, dated January 5, 2017, and a lumbar myelogram and post-myelogram CT scan from the Spine Hospital of Louisiana, done on the same day, January 5, 2017.
And for the purposes of this deposition, I'd just like to talk to you today about the neck or the cervical image that you looked at, okay?
Sure.
Okay. If we could, tell us a little bit about what a cervical a CT slash cervical myelogram is? How's that different from other kinds of imaging?
Well, in this test, in a cervical myelogram, we inject dye into the spine. This is typically done in the lumbar spine, and then we tip the patient with their head down and run it up into their neck region and take a whole bunch of x-rays of their neck with this dye there. We then move the patient over to the CAT scanner and do CAT scanner pictures through that area with the dye there. The important reason to do this is the nerves in the neck don't show up very well on just plain x-rays, CAT scans, or MRIs. So putting the dye in there floats around these nerves and outlines them and lets us get a really good picture of them, so we can tell for sure whether there's something compressing one of these nerves causing the patient's problem. And that's very important because there's very good evidence if the patient has a nerve that's being compressed and symptoms in the distribution of that nerve, then we know that doing an operation will help the patient, an operation to remove whatever's compressing that nerve. So that's the real purpose in doing this test.
Okay. Other than what you've told us about being able to visualize nerve structures, are there any other advantages or disadvantages of a CT myelogram over, say, an MRI or X-ray, for example?
Okay. Well, there are two. Number one is patients that have had a previous operation and have screws and plates in their neck. Those screws and plates cause artifacts and make the MRI images blurry. So MRI doesn't work all that well in patients that have had previous surgery. Number two is the CT scan, because of the way it works, is much more sensitive for looking at bones. So we get just a really good look at the detailed structures of the bones, and in this case, in the cervical spine. So those are the real reasons to do that. We see the nerves and we see the bones, and there's no artifacts.
Well, if we can, doctor, can you, let's go on to the actual image of the cervical spine that you have and get you to tell us about your findings.
Sure. And we'll just start with the CAT scan, and that's where all the interesting information is. So, I'll show these to the jury. But I gotta go up and start at the top. So here's an image starting at the top of Miss Singletary's neck. So this is a section from her CT scan post-myelogram. She's laying on her back and we're standing at her feet looking at her. So this is her right side, this is her left side, this is toward the front of her neck, this is toward the back of her neck. This white structure is the bone of her one of the bones of her cervical spine. This gray thing is her spinal cord, this gray circle. This white stuff is the dye that was put in there for her cervical myelogram. You can see these little shadows passing through the dye, and these are the nerves that go out to her arms. As I told you earlier, the reason we did this test was to get a really good look at the nerves that go down to her arms. And this is what I want it to look like. This is what a normal level looks like. At the top of her cervical spine was normal. If we step down to the next level down, C3-4, there's some very mild disc bulging. This is a section through her disc. This gray thing is her disc. She's got some bulging. You can see this gray thing sticks out just a little bit from the bone, but not much. Her spinal cord still looks normal. The nerves that go down to her arms still look normal. She's got some arthritis in her joints out here, but that's not a big deal. So some mild arthritis in her neck at C3-4. The next level down is C4-5. And at this level, she's had an operation. These are screws in her vertebral bodies that look normal. This is what I want them to look like. There's a plate here in front which is fusing this. There's a little bit of scar tissue around her spinal cord and nerves, but they're not being compressed. This again is one of her nerves that goes down to her right arm. Here's the one on the left. They're not widened. There's nothing squishing on it. It's just got a little scar tissue around it from her operation. It's important to look at the screws. This is what they're supposed to look like. They're supposed to have a nice, well-defined border all the way around them. If we go down to the next level down, this is C56, where she still has a plate here. She has these screws. The screw on the left has a little bit of lucency around it, meaning there's a little dark stuff around that screw. I'll see if I can get a better picture of that, which is important because that sometimes raises the possibility that the screw is loose. It's probably seen best in this view, and that is, this is the screw, and you can see there's a little bit of light stuff, or gray stuff, around this screw, suggesting that it's loose. Her plate doesn't look loose to me. The screw on the other side doesn't look loose to me. There's a little bit of gray stuff around it, but it's probably okay. And she's got a little bit of scar tissue around her thecal sac and her nerves. But again, we see her nerves really well, and they're not being compressed by anything. So just a little bit of scar tissue from her operation, and the suggestion that maybe one of the screws in her plate is loose. If we go down to the next level down, the screws look okay. There's nothing compressing her spinal cord or her nerves. The next level down is basically normal. Just a little bit of arthritis, nothing bad. So my conclusion was that she'd been operated on at C45 and C56. There is some scar tissue from the operation, but there's just about always a little scar tissue after an operation. There was the suggestion that the screws in C6 on the left could be loose, but the right screw didn't look loose to me. So there's a question that maybe her fusion wasn't completely solid, but I'm not absolutely sure of that. But again, since there's nothing compressing her spinal cord or her nerves, I don't think it needs any action. I don't think it's of any importance. And that was basically it. I then commented that lucency around screws is something we see not infrequently. It's not related to trauma. It's just one of those things that happens sometimes when we're fixing any bones, or the orthopedic surgeons or neurosurgeons are fixing any bones with screws and plates. Sometimes they don't stay solid, and that's just a risk of the procedure. There are risk factors that can make it worse. The risk factors being osteoporosis, which she doesn't really have terrible osteoporosis. Smoking cigarettes is a very big risk factor, and diabetes. But again, not related to trauma. Trauma does not knock these screws loose.
Doctor, when you say trauma can't knock screws loose, in this particular case, she had a plate. And I take it, were there several screws used to affix that plate over the operative site?
There are 6.
Okay. And you saw one screw was loose?
Maybe. Loose.
Perhaps.
I'm not even sure it's loose, but could be.
Would that impact the stability of that plate?
Well, it could if it was really loose. But I don't think it's loose enough that it would impact the stability of that plate. And the plate doesn't look like it's ever moved to me. There are none of the indicators that that plate is loose. So no, I don't think so.
What causes these screws just sometimes loosen because of that's just one of the risk of this type surgery?
Yep, it is. It's just one of those things that happens. You know, it's like building any structure with wood and screws even. You know, sometimes a screw you put in a board doesn't seat tightly and works itself loose over a period of years. That's just something that happens, and it happens in bones as well.
Now, I believe in this case, Miss Singleton had a fusion where some of her bones were fused together. Would you explain to us exactly what a cervical fusion is and how it works?
Sure. In fact, we can show the jury. Well, so on this set of images, this is data again from the CT scan, where we've taken this set of data and reformatted it with the computer to look like this. So we're standing at her side looking at her, and she's facing this direction. So this is toward the front of her neck. This is toward the back of her neck. This is up toward her head. That's part of her brain up here. And this is a section right through the middle of her cervical spine. This gray thing is her spinal cord. These white structures are the bones in her neck. Normally, a person bends their neck at all 6 levels in the cervical spine. The discs, which are the cushions between the bones, have some flexibility and allow that to occur. If, however, you have problems with your discs, usually those problems are disc herniations, the surgeons will go in and take out the disc, put a piece of bone occupying this space, and put a plate across it to stabilize that and make sure that piece of bone stays okay. And you can see that's what's been done with her at C4-5 and C5-6. She's had her disc removed, right? All this gray stuff is the disc. But it's gone here, and it's gone here, and there's bone in place of it. And she's got screws and a plate holding her neck in place. That works really well to solve the problem associated with these disc herniations. The downside is you are now, or at least she is now, only able to move her neck at 2 levels up here and 1 level down here. So she puts a little more stress on the other parts of her neck, but I don't see that that's done her much damage yet.
Is there a different bone plug at 2 levels here? Is that what we have?
Yeah, there are bone plugs at both C5-6 and C6-7.
Okay.
I'll see if I can get it to where they show better. Kind of hard to see, but there are bone plugs. Here's the one at C5-6. The one at C6-7 is a little harder to see, but it's still there.
There's been a suggestion by one of the doctors in the case that there was a crack at C5-6 in this bone plug. Did you find a crack?
No, there's not. And I looked at it again after I was told that, and I cannot see any evidence of a crack in the bone plug.
What would a crack look like?
Well, it would be a straight line, right? I mean, a crack is going to be, up here again. A crack is going to be a fracture. I mean, it's going to be a line.
Doctor, your microphone fell off, sorry.
Oh, yeah, sorry, I stepped on it. So it's going to be a gray line, the same color as this stuff, passing through these bones. And we see these bones really well, and there's just no crack in them.
So where's C5-6 on that particular one?
It is right here. This is 5, this is 6.
Okay.
So the bones of C5 and C6 are these two.
Okay.
So if there was a line passing through one of these, we'd see it.
Okay. I do see a dark object midway up on the left. Yeah.
This one?
Mm-hmm. Yes, sir.
That is an artifact caused by the screw. You can see there's one up here too.
I see.
And if you think about that now, you can tell it looks like a screw, right? It's got little spirals around it. And that's just because the x-rays have been deflected by the presence of this metallic screw.
Doctor, you've talked about screws sometimes loosening just as a result of one of the risks of this procedure. What about when a fusion or when the bone plug, as in here, cracks. That does happen, doesn't it?
Sure, it's part. If the screws get loose and this area moves too much, it puts stress on the bone plug, and the bone plug can indeed crack.
And it's because of the motion and the loose screws?
It is, exactly.
Is it caused by trauma?
No, it is not.
Now, Miss Singleton, she will testify that some boxes or something fell on her. Why wouldn't a traumatic incident like that be a possible cause of either dislodging a screw or causing a crack in that bone plug?
Well, I mean, just mechanistically, think about this. This level, this is the one we're talking about, C56. I mean, it's got a bone plug there. It's got a plate here in front with screws in both C5 and C6. So it's fairly well fortified. I mean, it's a strong level. If she got hit with something big enough to break her neck, it's much more likely to happen up here where there is no plate and screw. You know, I've been doing this for 30 years, and I don't think I've ever seen a traumatically induced fracture through a ventrally plated ACDF.
That would be a significant blow to cause any fractures, I take it.
It would.
It would probably be painful immediately, I would think.
Well, and again, it would move things. I mean, even if it were to occur, that kind of force would displace some things which are not displaced.
Did you, I may have asked you this, did you see any evidence that any of the other screws had lucency or has a possibility of being loosened?
No, the only one I was worried about is C6 on the left.
Well, you do have one screw that may be loose on the left at C6, is what you just told us.
Yes.
Wouldn't that cause some instability? Wouldn't that cause the plate to move around?
Well, it would if the right one in C6 was also loose. But since the right one looks like it's solid, I mean, that's like having a board screwed in with 6 screws. If you remove one of them, it's still going to be pretty solid. If 2 of them are loose, then maybe, but not just one.
Doctor, we expect some testimony to the effect that one of the doctors is going to say that during a subsequent surgery that, or he may say that we observed a crack. Do you think the doctor, if the doctor says that, assuming he does testifies to that, do you think he's wrong and he didn't see a crack?
No, he could very well see a crack when he's in there at the operation, but I don't see it on this study.
Okay.
And it's possible that she developed a crack between this study and her operation. That could occur.
Is it is the CT, I may have asked you this as well, and forgive me if I have, CT myelogram is more sensitive than an X-ray in terms of detecting a fracture?
Yes, it is.
Do you believe there was a crack in the bone plug at the time this study was performed?
No, there is not. We see that bone plug well, and there's no crack in it.
Okay. Thank you, Doctor.
Dr. Partington, again, my name is Peter Ellis, and I represent Miss Mickey Singleton.
Yes.
Were you provided with anything else during the course of your image review other than the CT myelogram study that we're looking at?
No, these were the only 2 studies I was provided with, the CT myelogram of the cervical spine and the lumbar spine.
Okay. And you mentioned the date on those were January 5th, 2017. Is that right?
Yes, that's correct.
Okay. And you understand that to be after the subject incident at Walmart?
Yes, the incident was dated October 15, 2016.
Okay. Now, Dr. Partington, you're a radiologist, neuroradiologist, correct?
Yes.
As opposed to a clinician.
That's correct. I do not examine patients or deal with symptoms.
Okay. But that's what a clinician does.
Yes.
Okay. And that's what a surgeon does, like Dr. Shambliss Herod, who treated Miss Singleton. correct?
Yes, he does.
Okay. But you're neither a clinician nor surgeon.
That's correct.
And in fact, you've never really laid eyes on Miss Singleton before.
No, I have not.
Okay.
And I still have not.
You mentioned these were the images you were provided. Have you ever seen prior imaging studies of Miss Singleton's neck before the incident at Walmart, whether it be CT scans, x-rays, MRIs, anything of that sort?
No, I have not.
Okay. So you don't have any evidence of what her spine looked like prior to the Walmart incident?
Correct. I do not have any information.
Okay. When clinicians and surgeons send their patients to an imaging facility for x-rays, MRIs, CT scans, you end up looking at those films, correct?
Yes. Yes, I do. If they were done in my office, I do.
But never at the patient.
Correct.
And you interpret those films.
Yes.
And you report your findings back to the referring clinician or surgeon.
Yes.
And that clinician or surgeon treats the patient as they see fit.
That's correct.
Again, you don't participate in the treatment of the patient.
I do not much anymore. No.
And you don't participate in the planning of surgery.
Correct. I do not.
Okay. Certainly, you don't see the physical body up close like Dr. Herod would during a surgery.
That's correct. I do not.
Okay. Additionally, you don't participate in the planning for future care like spinal cord stimulators or any other potential future treatment.
Correct. I do not.
So it's fair to say you don't participate in treatment at all.
Correct.
Is it true that sometimes when a radiologist reads a film, he or she might see something that another radiologist doesn't see?
Sure, that happens.
Same with a surgeon. A surgeon who interprets imaging may see something a radiologist doesn't see.
Yes.
And vice versa. Sometimes a radiologist may miss something that someone else does see.
Sure, that happens.
And in some films, there are findings that are very obvious
Sure.
that won't likely be missed by most skilled radiologists.
Yes, that's true.
Then in other films, there are findings that aren't so obvious,
Yes.
that can be missed,
Sure.
that are subtle.
Yes.
And in this case, Dr. Chambliss Herod may testify that he saw fractured bone graft. You know that opinion now,
Yes, I've been told that.
and you disagree with him.
Correct.
You were hired by Walmart
Yes.
to render an image review opinion
Correct.
about the very person who is suing Walmart,
Yes.
and you don't consider yourself a treating doctor
That's correct. I do not.
or a treating radiologist for that matter.
That's correct. I am not.
And your role was not for the purpose of treating Miss Singleton
No, it was not.
or planning a surgery for Miss Singleton
No.
or planning future treatment for Miss Singleton.
No.
Your role was not to help Miss Singleton get better.
That's correct.
You had a very limited role.
Yes.
And that role was to provide Walmart with an opinion,
Yes.
not for treatment, but for the sole purpose of this litigation.
Correct.
And your opinion may be different than Dr. Herod.
Yes, sounds like it is.
And this is the opinion paid for by Walmart.
Yes.
I don't have any further questions, Doctor.
Let me see if I've got any follow-up, Doctor. You were asked about subtleties in imaging. Did you find any, the core of your opinions, did you find any subtlety about the imaging upon which you based your testimony, that there was no crack or that there was one screw that was perhaps loose?
No, there is no question. We see these things very clearly, and the answer is clear.
Thank you, Doctor.
Thank you, Doctor.
This concludes this videotape deposition. We're going off the record. The time is 1:30.